come all to learn and grow. Welcome to the Village Talk Show. Come all to learn and grow. Welcome to the Village Talk Show. We discuss what people need to know, empowering them to learn and grow. We discuss what people need to know, empowering them to learn and grow. Give praises to Jehovah, from whom all blessing and knowledge will flow. Blessing and knowledge will flow. The Village Talk Show, dedicating to empowering the community to live a healthy, safe, and financially capable life, helping each one of us in realizing our dream at any age, any point, starting from today, day. Success. Come all to learn and grow. Welcome to the Village Talk Show. Come all to learn and grow. Welcome to the Village Talk Show. We discuss what people need to know, empowering them to learn and grow. We discuss what people need to know, empowering them to learn and grow. Success is not spoken, it is done. Success is done. Come on now. The Village Talk Show. Talk Show. The Village Talk Show.
Hey, good evening.
Good evening, fam. You know how we doing? Welcome to the Village. That's good, Joanne, John.
Hey, good evening. How are you?
Doing excellent day.
All right. Hey, John, what's up?
Hey, what's going on? Got a damn bone stuck in my throat.
Yeah, you know what they say we must do? Eat some bread, so I can push it down. How you end up having that happen?
Piece of fish, man.
Usual.
Yeah. Hey, good evening, Benev. Thank you for joining us. Thank you so very much for joining us this evening. Maxwell Waterman, thank you again for coming on this evening. Our listeners, we need you. We're excited to have you on tonight. Lots going on. We have a guest that'll be coming on around 8, right, Andre?
Yeah.
Around 8 o'clock. This is a approved guest from Mr. Daly in advance. So, yeah. So, of course, we're definitely going to keep it moving. Oh, my goodness. This week it went by so quickly.
For real.
Yeah, because just the other day, I feel like it was Sunday, and then your blink is Thursday. So, that's a good thing, but that means we're getting closer to the end of the year.
Yeah, time go by quick.
End of the year?
Yeah.
It's only freaking May. You talking about end of the year?
Listen, when it start rushing like this, it's towards the
Why
end.
are you rushing, man? Well, shit, let me enjoy a little weather then.
The weather still didn't come in. I have to wear, please. Next week is supposed to be in the 80s. Then we could talk about.
I heard next week's supposed to be in the 90s, not 80s, Doc. Get it straight, Doc. Tuesday and Wednesday, 90 degrees.
What did you hear, Andre? 80s or 90s?
I didn't hear, but either way, 80 and 90, like this is the same. It's gonna be hot. It's gonna be blazing. So, unless the weather decides it want to go back.
That means beach season.
Yeah, where you gonna go beach? You go beach in New York here? Or you gonna travel?
Listen, wherever it is, it's beach season.
You gonna be traveling?
Don't worry about that.
Gonna be like like Roderick. One of the shows them you pop up. Hey guys, next thing you know, you're in some Caribbean country enjoying the beach.
Hey, listen, nothing wrong with that.
Mm-hmm.
Hey Chris, how are you?
I am doing well. How are you guys? I heard about beaches.
Joanne says beach season. She's gonna be at the beach the next show.
Let's do it. Absolutely. Yeah. So, I want to travel like our president traveled. Right now he's in China enjoying the good life.
Good
Have
life.
it.
What? Good life. My man's over there trying to like get some business deals. Would presume.
I don't
Yeah,
know. He's enjoying the good life, traveling around the world and, trying to calm this war.
the
But I
one that
don't know.
he really pushed to start.
Yeah, there are many saying, hey, it's your business, it's your deal, it's your ordeal, your mess. You deal with it.
But because of all of those things that's going on, really, him going over there, and he brought up a bunch of CEOs on there. Tim Cook, Elon, Jensen, like a bunch of them over there with him. So this is about business, and the market sees that they cut the market prices expectation. So they're like, "Oh, it's gonna be good." And what you got? S&P running, Dow Jones running, Nasdaq running. You know, so it's hopefulness, but risk, the risk. What do you call it? Is around the corner right there if people don't be mindful, you know.
So, do you think that the deal, the conversation he's been having is going to be successful? Partnership? Do you think?
I don't know if necessarily successful, but even research shows even like the last 20, 30 years that midterm years, the 12 months following the midterm election, the
Hmm.
market's gonna be running high, and it's because the market's already pricing in the certainty. Whether he wins or not, they know exactly what's the next 2 years gonna be like for the most part. You
Mm.
know, um, right, Chris. Like you would agree in that sense.
Forgot that I was on mute. Yeah, I mean, I think a lot of this is already priced into the market.
Yeah. So, but I mean, we can go with what John says. He's enjoying the good life. Oh
Yeah,
man.
but you know who's actually winning? Who's benefiting from the war? China.
Oh,
They
what do you,
are.
what do you see in that show that?
They're definitely benefiting from this. Hey, wasn't it just a couple of it was just last year he was threatening China. He's gonna double their
They
tariffs
still
and
got
all of
50% tariff. They still have 50% tariff, and
that.
Mm.
Yeah.
and they still the Strait of Hormuz is still closed,
Yep.
so their oil prices are going up too. So I don't know how she is benefiting.
Well, I think it's also the fact that they have so much reserves, but I mean reserves won't last you still though. But yeah, I
Yes.
think and the that I saw data came out that there was approval to use Nvidia's chip, and Nvidia is like the largest AI company right now, and so there was a deal that approved they could use the chips for Nvidia. So I presume even that deal, there must have been some sort of stipulation. I didn't get to see anything else regarding that. I'll read up more on it. Um, but yeah, man, like the market has been running. The market has been running, and so
Let it run, baby. Let it run.
you know, people, positioning is an important thing that people to do. And just again, and this is just education. So be mindful, if you interested in financial stuff, you want to make sure you have a financial advisor. Just want to make sure we put that out there, right? This is really education. So just keep those things in mind.
Absolutely. Do you think that we're gonna have a partnership with China after all the tariffs, like you mentioned, John, 50% tariffs and everything?
There's always going to be. I don't. There's always going to be a partnership. There's always going to be a partnership with China regarding other issues.
As
It's
many things.
beneficial for both parties.
Yeah, we purchase a lot of things from China.
Made in
It's
China.
beneficial for both parties.
Made in China.
No, I mean they're not being hostile, but I think the one sticky point in this whole relationship is United States involvement with Taiwan.
Hmm.
That's like a red herring for China.
So do you think that they're going to, well, Do you think that they're gonna walk away from Taiwan?
I don't think they're going to walk away from Taiwan. No, they might they might slow their dealings with them, slow it down a little bit. No, they're not going to walk away.
Similar to what he said, Trump has said he was gonna work and support Ukraine, and it's like dangling a carrot to say, "Yeah, we're gonna do this. Come meet with us or whatever." I feel like it might be the same with Taiwan.
It could be. It could be. We have to wait and see approach, but I think we need to stay vigilant. Keep communications open with Taiwan. We can't let Russia. We can't let China run unobstructed. You know.
Yeah, it's U.S. interest. As much as we may not necessarily like how some things are go ahead. It ultimately is gonna impact us. You
It
know,
does impact back. To all the listeners out there,
yeah,
it does impact us from the
yeah,
gases and the items that we purchase.
Mhm.
Everything it has increased
yeah,
So,
because of decisions that have been made.
yeah, without really being counseled. I think many decisions that was made is underestimating the power of someone else, different individuals. War, especially when people go into war, they figure that, hey, you're a weak party, that I can just do this or just do that. But at the end of the day, you never know what they have planned. You never know what the person have um set up. That's the thing.
And what they have is the Strait of Hormuz. That's what they have. That
Mm.
can really, if oil hits $200 a barrel, do you know what type of economic impact it would have on the global economy?
Well, it's felt worldwide. This war is
Exactly.
felt worldwide.
Mm-hmm.
It not only impact the United States, it's impacting everywhere.
Hmm.
Europe is upset. Africa is upset. China's upset. Russia is upset. So it is a connecting bridge.
yeah.
Well, so have you guys ever traveled in Europe and seen what petrol costs in Europe?
No, I haven't. Mm-mm.
I never
So,
had to do it, like, because you go there, you get driving the taxi or the bus or whatever
yeah, I mean,
transportation you take.
if you drive by a gas or petrol
Yeah,
station, called petrol, what you'll notice is that it's priced in liters, which
yeah,
obviously is smaller than a gallon. So
Mhm.
then when you multiply that by 4, we actually still have it with like compared to Europe, our
Mhm.
gas prices are way cheaper.
oh yeah, oh yeah, oh yeah.
So if we're upset,
Yeah.
imagine how the
Imagine them,
Europeans feel right now.
imagine them. No, for real, for real. So we're just looking here back at home too. Um, just even I think John made a comment the other day that he had to fill up his tank and he had to switch from premium to regular. Like, so I just imagine just people across the world and how they're feeling regarding that itself. I often look at just sometimes, and this is not downplaying anyone's own difficulties. Sometimes I just look at what we have here, and I'm still thankful because I just imagine somebody else and somewhere else, and they're
Mhm.
just feeling that pain like it's unimaginable times. Um, so that's something that has to be considered. But hopefully this meet, as unpredictable as our leader is here in the US, the hope is that some sort of deal comes through, and the strait can be open. So I'm just definitely keeping an eye on that. Um, by the way, our guest is here, so in about 10 minutes, and everyone can jump on to another topic real quick and then bring him on.
That sounds like a plan.
Yeah.
You
Uh,
know what? I have to say this. I am tired of it's not even summer yet, and people
yeah.
are reckless.
Yeah.
Reckless. The poor little 5-year-old girl who actually got grazed by a bullet walking with her mother is so unnecessary. Like, why? She is 5 years old, entitled to play around, to be safe with her mom, walking in the street. So now we're saying we can't go to a store, we can't come outside or whatever. That is reckless. That, hey, if you decide you want to have a shootout, war, do it on, do it somewhere else.
You know,
Not, and there's places for everything. There is the military. If you really want to shoot up,
go join the military.
join the military. They are searching, actively searching for participants. And listen, they won't say no, since that their skill in shooting, they're not that skilled. Because the thing is, if they were skilled, they would not graze an innocent bystander. But hey, there's always place in the army, the navy, the marines, all of that. They use guns. So please sign up and leave the innocent people to be. That's my take. What is your take on that?
Well, I mean, I don't know if I would say, there's places. I feel like there's not enough done. I think about this of how just the use or grow up or the accessibility to the weaponry,
Mm-hmm.
right? Yeah, I think about all those things really, and it's just it's just worrisome, because I just imagine people bring their kid in the world and just wanting to be able to just walk on the road and just really just be able to enjoy a moment. I mean, what time was this? What time did this happen again? Like what time in the
This
night?
was
Night
in the afternoon, actually.
afternoon. And that's the wildest part too.
Afternoon.
Like broad daylight. There's the honor among men. I remember that quote is out. There's no honor among men. There's
No,
no honor.
no
There's no
respect.
consideration. I'm not for the violence and all that, but it's like, shoot, we throw hands. We throw hands. Like, what happened to that, bro? Like, it just it's disheartening. And I just think about the kids, because over the years we've read stories, news
Mhm.
stories of these happenings. Remember the one where the baby got shot in the park, that birthday party, and the baby got shot and killed. And oh my gosh, like that the to say disheartening understatement. I couldn't even imagine, and I'm just saying, what else? What is being done? It's so
Thank
much.
you, Maxwell. I agree. There is a place for everything.
Yeah.
But there was another gentleman who actually got shot up in Brownsville. He was a young gentleman that actually was an educator, educating young people. He's part of, I was listening to his story because he graduated from PS 150, one of the schools I worked at years ago. But it's unfortunate because the thing is, he came back to the community, still live in the community, but came back to the community to help young people stay off the streets. He
Hmm.
got killed on the street, like steps away from the community center and his house. Like, come on.
It is
Come
wild.
on, people. He's working two jobs. He was doing construction. And in addition to that, he was working in the after school program, about to get promoted. He had a meeting with them, telling them about his promotion and he's moving up, and didn't even make it out.
It's crazy.
Like, hey, you're going home to go and tell your family and everything. It is heart wrenching. Our young folks are getting slaughtered
Yeah.
by people who are careless, and it's not right. It is not right.
Sad,
And
man.
summertime is not even here yet. So we need our community leaders, we need our politicians, we need the village to become a village again, because it is May and we should not see our babies get murdered and killed and slaughtered before they even get a chance to live. So please, I beg, if you have a way to grab up a young person and help them out, you know, please do so. Please do
Yeah.
so.
Yeah.
So, I mean, obviously, this is senseless. And
Mhm.
I like what you said, Andre, about what happened to just throwing down.
Yeah.
Like, I mean, I don't know about you, Joanne, but I'm sure, Andre, I know I got snuffed a few times. I know I snuffed a off you guys.
Bro, I remember.
Like, I guess what I wanted to ask you guys is, to what extent does this happen because kids or young men and women just feel like they have nothing to lose, like they have nothing to. If you give someone something to lose, then they're going to protect it.
Yeah.
And if they know that there's nothing to lose, what are they actually protecting? So how do we give them something to lose so that it doesn't get to this senseless violence with gunfire?
Yeah. So they have no hope. That's what you're saying.
Right. I personally believe that it's because they have no hope, and I always feel like the economy has some role to play in that. Like, why would I feel like I have to resort to this? Because I have no hope.
Yeah.
Right? If this is indeed gang violence.
But it's also the association that you surround yourself with as well.
True. Very true. Very true.
Birds of a feather come together.
Yeah, because you might be right about that. Hey, you know what? If I can't get a job, if I can't go to school, if I can't do anything, so what am I going to do? Stand around and rob people and shoot them? But shooting them is not going to get you the job.
Yeah.
So it's like, hey, use your brains, because at the end of the day, you need common sense.
Yeah.
To survive.
For real.
And the thing is, people are not going to give you anything if you don't strive and aim for. So that's part of it.
Yeah. Yeah. So, and this, connects to health. So I definitely want to bring in Dr. Blokh. To try and come in. Pretty sure is okay, but let's see the mic. All right, thumbs up, Dr. Blokh. You ready? All right.
Do you hear me? Oh, now I see myself.
I hear you now.
You.
So we all good.
Hello,
Oh,
and
hello.
thank you
How
for
are you?
joining us.
Thank you. Thanks for having me. I just got a delivery 2 hours ago of rundown Jamaican food
Oh Lord,
from the
I
door.
love it.
Yeah, just got a big delivery.
Right, tell me the door is your place.
Yeah, every week. Yep, I just got it.
And you got it delivered from the door?
Yep, nice and hot, scorching hot. Joanne delivers it to me. Yep. Oh no, not you, Joanne. The owner of the door. I just realized you're Joanne too.
Oh, I love this.
I meant Joanne, the owner of the door, not you.
Oh, I love this.
No, you don't have to deliver me
Like,
anything.
Okay.
So what did you get? I want to hear.
Well, I got oxtails. I got rice and peas. It's a whole package. I got my own personal meal, a rundown salmon with rasta pasta, but healthy rasta pasta, not the cream, but the olive oil rasta pasta. And I get their pound cake, cheesecake, their pineapple ginger juice, the plantains, their salad, and then I get their cold jerk chicken macaroni salad, and I get, what else they give me?
Is this for the week?
And curry goat. No, what I do is I don't eat any of this stuff actually because my stomach can't handle. And jerk chicken, I can't. Especially the jerk chicken will kill me. So what I do, I can't my stomach can't handle this. So it's good public relations. So what I do is I have my staff, a little bit eat, whoever wants, and I bring it to the night. Usually the night crew is usually heavily Caribbean, more than the day crew. So I'll bring it to the night crew in the hospitals. So it's like heavily Caribbean. So I'm very popular with the staff in the hospital.
Okay, so we're gonna rewind and come again. Dr. Blokh, you're gonna have to introduce yourself to our listeners, because you mentioning food. You started with the right word, food, the door, and then went straight into the food, and then you mentioned hospital. So, ladies and gentlemen, if you want some Caribbean food, follow Dr.
Well, you gotta
Blokh.
work for me. Work in my office. I'm always looking.
So please share with our listeners who you are and where you are coming from, what hospital you're affiliated with, and what field of line. So I'm gonna pass the mic to you.
Thank you. Hi, Joanne, Andre, Christopher. Thanks for having me into the audience. So my name is Ilya Blokh, and I'm a general hematologist, oncologist right here in Brooklyn, New York. And I'm right here in the middle of Brooklyn on Kings Highway, I got a bird's eye view of Mount Sinai Brook right through my window, and pretty much see all kinds of patients. General kind of bread and butter hematology oncology.
Let me tell you, hematologist is so popular. Just today, I was speaking to someone about the fact that they tend to eat ice, nonstop ice. And I was like, oh, you might be iron deficient because they're always eating ice. And they was like, yeah, they did say my iron in my body is good, but the forensic or something she was saying
Oh,
was low.
yeah. So ice, eating ice. Unless you're a overworked hematologist drinking ice all the time, trying to keep awake, most of the time, ice is a sign of iron deficiency. There's a lot of things that kind of red flags that someone could be iron deficient. Eating ice is called pagophagia, is definitely one of them. People could feel tired. Sometimes I ask the patient, "Hey, are you losing hair?" And they said, "Oh my gosh, I thought it was just me getting old." And I said, "No, but you're young. Why are you losing hair? Hair loss, cold intolerance, restless legs, tired, nail changes, tongue changes, a little bit of irritation on the sides of the tongue. It's called spooning of the nails, and there's all kinds of medical terms for this stuff. Palpitations." Palpitations, dyspnea on exertion, meaning when you kind of have to move around a lot, run steps, or do a lot of walking or running, all of a sudden you can't catch your breath. All these things, headaches are very common. So all these things could be a sign of iron deficiency, and it usually very frequently goes unrecognized, or you got to kind of put everything together to figure out that this could be iron deficiency.
Wait, you said headaches also when you
Oh,
have
and
it?
yeah, that's one of the questions I asked. Do you have headaches? I mean, headaches could be many things, but especially in the setting of a young female with heavy periods and all the other things that I mentioned, then it fits together that the headaches are most likely could be from
I never knew.
headaches is tricky. Headaches, a lot of people suffer from headaches. Sometimes a headache that wakes you up in the morning could be something more serious. So headaches obviously got to be investigated. But if it's headaches, chronic headaches, that there's no worsening of them, and in the setting of all the other factors, that's really could be iron deficiency.
Wow.
And I'm really big on iron deficiency because it's so common in the community that I serve. I think in general, one of the things I love about treating iron deficiency is it's one of the only things that is almost certain in medicine. You know how they say there's nothing 100%, right, except death and taxes. Well, I would add to that and treating iron deficiency, because when you treat iron deficiency, especially if someone needs IV iron, and sometimes people need oral iron, but if they get IV iron and the iron deficient, it's literally almost 100% effective. And
so is that iron transfusion?
Exactly. But so
I did that before.
Yeah, but there's actually specific indications. So I don't just push it on everyone. First, the patient has to try oral iron, right? They have to try pills, or they can't have critically low blood values, because if they're critically low, they need IV iron. But if they're mild anemia, I'll let them try oral iron first, see how they tolerate it. If they can't tolerate iron, if I give it to them and it doesn't help, either they don't absorb it in their system. There's many reasons that someone would not absorb it. They could be on antacids. They could have surgery for weight loss. They could have many reasons why they can't absorb it. If they lose more iron, then they could take in. So your iron levels are based on how much you get in versus how much you lose. And if you're having terrible bleeding for whatever source, and we're not catching up by giving you the pill, that's another reason to give you IV. But once you get IV, it's pretty much certain it's going to work, because it's IV. There's no issues with absorption. It goes right into your body, and patients feel so much better once they realize, that, hey, that's all from iron, and now that my iron levels are better, I feel like $1 million.
Now I have a question for you. I did do iron transfusion prior. What I did realize is that after doing iron transfusion for several months, I blew up. So what are the chances of people getting bigger after the iron transfusion.
Right. So that's interesting. So um, I have a theory why may that may have happened with you. So with iron, a lot of times there's risks of reactions, and the reaction could be an allergic reaction or it could be just an infusion reaction. Now,
Mm-hmm.
infusion reaction is much more common than allergic reaction. Allergic reaction is very rare, but a lot of times hematologists try to prevent these things by giving pre-medications at the time of iron. So one of the pre-medications we give is steroids. And if you've gotten iron, if say you got a weaker iron and you got it more often, and you got pre-medication kind of frequently, and that pre-medication involves steroids, steroids kind of could make you blow up. I usually counsel patients, hey, if you get steroids, watch your sugars. It can make you a little hyper. You may have trouble sleeping at night. You can gain weight, but usually not the steroid that we give once a month. It's more if you get steroids more frequently, say you get a weaker iron and you have to constantly get steroids with it. So I suspect you may have blown up from getting some steroids. I mean, iron itself, unlikely to have made you blow up. It's very well tolerated. One of the things I say is, hey, it's much safer than getting a blood transfusion. So if you really...
That was my reason for getting an iron transfusion. I said, no one other, I didn't want someone else's blood, because the thing is your body might react a certain way. Not everyone's blood is good for you.
Yeah, I mean, with blood transfusions, you run the risk of infections, but they screen the blood these days, but nothing's 100%. You also, there may be some immune effects on your body by getting someone else's blood. So definitely, I would say if you could avoid it, and if you get IV iron instead by catching it earlier, you're better off than waiting, being in denial, or just kind of not wanting it for whatever reason, and becoming so critically low that now you need a blood transfusion. And also, some people can't get blood transfusions because they may be Jehovah's Witness. They may not want, or it's against their beliefs to get blood. And in that case, IV iron is really the best route for them. Wow. So I think you did the good thing to get IV iron and not let yourself get out of hand until you really needed a blood transfusion. Remember, being very anemic is a big tax on your body, because blood has oxygen. Your body needs oxygen. Your brain, your muscles, your heart, your lungs, your diaphragm, all your major organs need oxygen. And so when you are anemic, the way I kind of equate it to patients is like walking around with a huge dumbbell on your neck. You're walking around with a tremendous weight. You have trouble breathing, you're tired, all these things. And so it's a big tax. And some patients who have heart conditions, remember the heart is a muscle. And so you're depriving it of oxygen by having low hemoglobin. That's a stress on your heart that could precipitate, heart attacks. If they have arrhythmias, when you're anemic, you tend to have tachycardia or fast heart rate because your heart is trying to compensate by beating more blood to all your organs. So you could precipitate worsening of arrhythmia. So there's a lot of consequences to walking around anemic when that could be easily fixed if the causes are iron deficiency. So remember, the first step is to see that the patient may be anemic, but not all anemia is low iron. We need a hematologist or at least a primary care doctor to do further testing to prove it. But the good news is a low ferritin, and that's the word you were looking for before, is diagnostic of iron deficiency. There's nothing else that causes a low ferritin but iron deficiency. So if we do a ferritin level and it's low, you have iron deficiency, period, end of story. There's nothing else that you have. So the diagnosis is pretty certain at the low ferritin level.
Is there chewable iron pills?
There's a lot of iron. There's a lot of irons. There's liquid iron. There's all kinds of irons available.
Because a lot of teenagers tend to be iron deficient, especially the girls. And many people still, as adults, don't like to swallow those iron pills. So what's the alternative? And they might not want to get an iron transfusion either. Yeah. So it's like, what do you? And that iron liquid doesn't taste good. There's usually a bad taste.
I have to admit, I never tried it. I mean,
what about the greens? eating your greens too. Does that?
Yeah, there's foods rich in iron. Although I always say if you're low in iron, you really can't eat your way out of it. You really need a little help.
Yeah.
There's a lot of irons on the market, and the thing I would warn you about is sometimes they claim that their oral iron is the best, and they'll charge you a lot of money for a superior product. But all they do is basically take the same iron as everyone else, and they'll combine it with vitamin C to make it absorb better. They'll add a little stool softener to make it less constipating. So all they're doing is basically combining ingredients that are available and then charging you an arm and a leg for the same thing. But there are some irons that claim to be better tolerated. There's a new one recently that I'm using. I don't want to make it into an advertisement for it, but there's a new iron that's recently made from England that's supposedly better tolerated and better absorbed because it's absorbed further along in the stomach system. And that iron potentially is good for people who have a lot of inflammation and may not be absorbing iron well, and it has less side effects. So that's my go-to iron. Actually, let me go ahead and call it by its name, just because to be more precise. Ferric maltol. It's ferric maltol is that iron, and that's the one I'm using frequently when I need to give pills. But of course, it costs a lot, and that may be potentially get us into a conversation about cost and access and affordability, and then maybe politics and finances. But that's an issue, is that it's a very expensive iron, and that has limited the availability of it to everyone.
Right.
This discussion is really resonating with me because in all 3 pregnancies, my wife had iron deficiency. But another thing that's going to sound silly, probably, as you were talking about ice and eating ice, my 3-year-old is obsessed with eating ice. Is there anything there, or is it really?
No. At 3 years old, being iron deficient, I don't think that's such a big thing.
Probably not. No, probably.
Yeah. All right, good.
Like I said, you're gonna see me drinking ice and eating ice. I don't have iron deficiency.
But no, I have a lot of family members or friends who would just chew buckets of ice, and I'm like, that's not good. That's not.
If you put some liquor in it, it'd be all right.
No, it's no liquor in it. It's just straight ice. But thank you for touching that, because that is something that people are not aware of when they are iron deficient, but don't know the telltale signs. And you went down through some of the telltale signs that you might need to go and check out your doctor in order to figure out if you are iron deficient. So.
Yeah, and if you're anemic in general, then obviously that's where hematologist comes in, because sometimes people are breaking down blood in called hemolysis. Sometimes there's all kinds of reasons to be anemic. Now I would also segue that into saying, let's look at the patient and where they are in their life. For example, a young female, that's probably iron deficiency from heavy periods. That's the most likely cause. Now, at a different kind of segue into colon cancer, for example, what if you're middle-aged and you're iron deficient? Now it's a different conversation. And that potentially could move us into a discussion of colon cancer, because now when you're low in iron and it's not your periods, the question is where you're losing blood. And the first step is to look at the gastrointestinal system and make sure you don't have a cancer in the gastrointestinal system, anywhere from the esophagus all the way down to the rectum.
What would you consider middle age? Because people in there.
Doc, don't tell your age, Doc. Come on now.
I'm not talking about me. But what would you consider middle age?
Yeah, I mean, well, I would say in general in the 50s. But with colon cancer, I got to give you an update. They've lowered the age of screening to 45. So now we're really starting to screen patients at the age of 45. And the reason...
Becoming more serious, or is that what's up? Is it becoming more serious at a younger age? Or?
Yeah, because we're finding more and more people being diagnosed with colon cancer at a younger age. I've seen people in their 20s, 30s, 40s.
What's going on?
So that's very controversial, and I can't claim to know 100% the answer, but it may be a combination of multiple factors. And what people are talking about is, for example, obesity. Well, obesity is a risk factor for pretty much a lot of cancers,
Yeah.
pancreatic and breast, and a lot of cancers. So
Mhm.
there's a big obesity epidemic in the U.S., and that's a public health, crisis, you could say. So obesity, sedentary lifestyle. I mean, all the young people now sitting at the computer with the joysticks and playing, on their
Going outside.
computer.
Touch
Everyone,
grass.
yeah, no one's moving around, no one's exercising.
Mhm.
So sedentary lifestyle, obesity. Um, there's a concern that even a lot of antibiotic use is affecting what they call the microbiome. This is basically a collection of germs that we're all born with from birth, and it's
Mhm.
altering that uh, collection of germs by using frequently antibiotics. You have a little infection, any little thing, the doctor gives you antibiotic, which is not to say that you shouldn't take them, but the frequent prescribing antibiotics may be altering the kind of bugs that are growing in our system. Um, Basic, a lot of additives, preservatives, and that's also becoming a political issue. I've been hearing in the news, they're trying to really cut down all these additives and preservatives that the food industry is using.
Yeah.
Plastics. I recently heard in the news about they did some studies where they sampled individuals, and they found a lot of plastics in their blood, right? So these
Wow.
Oh
microplastics.
wow.
I mean, think about it. Everything you use has plastic. You store your drinks in you drink plastic bottles. So
Mhm.
there's this big controversy I've noticed in the last, I would say, 6 months or so, where I've been hearing a lot in the news and in the media about people they found plastics in their body, and the question is, are these microplastics harming us and potentially causing diseases, including cancer? So we're looking at a lot of potential causes, and it's probably going to be very, very hard to pinpoint one specific cause. It's going to be very, very difficult.
Yeah.
Wow. The
But
whole plastic information is like mind blowing.
yeah, you probably drink a lot of. You probably think you're trying to be healthy and drink a bottle of
Water.
but yeah, plastic water, right? A bottled water every day, right?
Mhm.
Yeah, you never know. You never. It's hard to say, but I personally just get my water in glass. That sounds like the healthiest. You
Mhm.
use glass. But
Even those iron, the flask, the metal bottles. Well, it depends on what
They have
kind.
so many recalls on the metal bottle. I keep getting recalls from Amazon left and right
The
about.
iron flask, like the iron flask itself is. I mean, I wonder if that's itself would be better, but I
hard
guess
to yeah, it's hard to know. I mean, you can't run away from. I guess you can't run away from death, right?
that's
But
true.
I mean, but I guess the ideal is to just lead a active lifestyle, right? Exercise, keep your weight down. You know, these are basic common sense things that people, I guess, in general should do.
Yeah.
Yeah, but when it's your time to go, when the man has said it's your time to go, it's your time to go, irrespective of all of that.
Right, and I think part of it is also luck. I mean, I've seen just people do everything right, and they
Yep.
do everything right, and they end up with cancer. They end up dying at a young age. It's very difficult to predict, but some things I've noticed, are more common in certain populations than others, and sometimes it's genetic, right?
Yep.
It's cancers run higher in certain groups of patients. So there's a lot of factors. It's very, very difficult you know to prevent everything in life, right?
True.
Yeah, but I'm seeing that a lot of the older folks now are being diagnosed with cancer. Like some that's in their 70s. I'm finding more and more people in their 70s and 80s who, maybe come from the Caribbean island. Here and there, every day you're getting a news that this person is diagnosed with cancer when actively at home, back home where they were very active. So I'm finding more and more 70-year-old people have been recently been diagnosed with cancer.
Yes,
Yeah.
because you know why? Because if back home you had the fresh food, you didn't have all the preservatives, and you had all that. You had fresh food. You
Mm-hmm.
had fresh food, nutrients. You had everything. You go into the, you would go into the, you can go into the fields and get your food, get fresh foods, without all this, without all this fertilizer and all that other stuff impacting it. So the fish, you catch the fish straight from the sea, and eat instead of being farm raised. So it's a combination of things.
One
Mm.
other thing that we haven't really talked about is where do all of you hold your cell phones? I know I hold it in my pocket.
Me
But
too, man.
like,
Radiation.
yeah,
You never
like
know.
what about that?
Yeah, I mean they did studies. I remember on the news there was at one point a lot of talk of cell phones and brain cancer, and I mean I don't think it's anything definitive, but what I do is I definitely try to use a earpiece, or I just hold my
Earpiece, yep.
I put my phone down on my desk. I don't keep it on me. I mean, it's basic small things that you never know. I mean, 10 years from now, there may be a different study that may show something differently.
Yep.
So I think it's reasonable not to like hug your phone all the time. Just put it down. Put it on the stand. Use a speaker, use a headphone.
Yeah,
I
let
think
it go, let it go, let it go, let it go.
Point. It's a good
All
point.
right. So I'm going to ask you, please tell us the difference between localized care versus national trends. So I'm interested in finding out your feedback on that.
Yeah. So I mean, there are things that large centers offer, and what we're trying, the trend in general, kind of the big picture trend, is eventually whatever's available on the large centers eventually translates into the community setting. And I could say, for example, regular chemotherapy, it's the same chemo whether you get it at Sloan Kettering or you get it locally by a local oncologist. It's the same drugs. It's the same chemo. It has the same side effects and the same benefits. Um, Obviously, certain things large centers could do that individual providers or even small groups of providers cannot. For
Mm-hmm.
example, people get what they call bone marrow transplants. I mean, you
Mm-hmm.
need a whole infrastructure and you need a hospital setting, and so that's impossible to do in the community. Impossible. But in general, I would say a lot of the treatment they start at the big centers, and as we get familiar with the treatments, and as we pinpoint and evolve the treatments to make them more tolerable, they slowly trickle in and are used in the community. Now, what I do in my case is I actually, because I've been working a long time, I would say by now about 20 years. So I have a large network of hospitals, subspecialists that I work with. So I'm able to give the patients the best care. And at the same time, whatever they could get in the local community, I'll give them locally. So, for example, and I don't pick one specific hospital. I basically pick individuals that are experts in specific cancers that I'm comfortable with and I have a good relationship with, and I
Mm-hmm.
work with them. And there's literally specific individuals in almost every large hospital that I work with. So one guy is an expert in lymphoma. I'll send them to, for example, Cornell. Mount Sinai has a huge multiple myeloma division. In fact, their head is one of the guys I kind of worked with way back when he was in St. Vincent's. His name is Dr. Jaganoff. So I send the patients that have multiple myeloma to Mount Sinai. That's the
You know
biggest.
what? But I think Methodist has a good. I guess this person, Dr. Dosick, with multiple myeloma.
He's basically a general oncologist like myself.
Mhm.
He's a general oncologist. I know him. I went pretty much I went to school with them at SUNY Downstate. So they're pretty much general on chemonc, just like myself. But there are
Mhm.
myeloma experts that only do myeloma.
Right,
And for example, if someone needs my transplant for myeloma, so I
right.
work in conjunction with those doctors. Columbia has a doctor that
Yeah.
specializes in MDS, so I send them to that doctor. So that's why I think my patients are able to get excellent care, because I'm able to guide them to who only does that specific disease, and I work together with them. I have good communication. I have their cell phone numbers. They have my number, so there's really good communication and good coordination of care, and that gives patients access to care even if they're living here, and the care is being coordinated with the city.
But Doc, like anything else, it's all about preventive maintenance, from your car to everything else. And I guess what people need to do to put themselves in a position to, I guess, to possibly slow the onset or sometimes to avoid it. So, what preventive measures that people can pretty much do.
Yeah, I mean, I think basically the usual cancer screenings. Well, I would backtrack first. Obviously, a healthy lifestyle that we talked about, right? The weight under control, exercise, eat healthy. That goes without saying. But in terms of specific cancer preventions, we do have a few. For example, women get Pap smears, colonoscopies now at 45, not 50, mammograms at 40. Um, um, and those are PSAs. The PSA blood test has been controversial, but I do it, and I think once you hit 40, 45, especially if you have high risk, I think it's worth checking a PSA.
What's the PSA? Can you elaborate on that?
PSA is a blood test, prostate specific antigen. It's a blood test. Um, there was some controversy at one point. The government agencies tried to stop people from ordering as much, and then things backfired where we found that then more patients ended up getting diagnosed with much later disease. So now it's kind of used a little more again. But basically, it's a blood test that a doctor could order on you, and it measures that level PSA. And if it's abnormal, if it's elevated, it doesn't necessarily mean you have cancer. It could be many other causes. Sometimes people have enlarged prostates, and the PSA may be higher. But if the PSA is elevated, it's actually a reason to look further. Usually a urologist would be the one that would then start investigating and deciding what to do. And I would say, even if they find cancer, not every prostate cancer patient even needs treatment. There are some patients where what they call low risk disease, where they may have prostate cancer and they're just observed. They don't even get, the prostate removed. They don't get radiation. They don't get hormones. They're just observed. And that's called active surveillance, where we're actively watching them and actively checking up on that prostate cancer, but we're not doing anything because it's felt that it's so low risk that it's unlikely to cause harm. In fact, when people had autopsies at death and they autopsied, all kinds of people, they found a lot of prostate cancer that people never even knew they had. So the question is, why would you want to do something and potentially cause more harm to the patient and just leave them alone? So
Right,
depends on the risk, it depends on the stage, it depends a lot of factors that go into deciding whether you need treatment for the prostate or not. But the point is, an elevated PSA at least starts the discussion and at least potentially could catch it early and not let it go all the way to the rest of the body. Because once most cancers spread, I would say the majority of these solid organ cancers, once it spreads far, far, far away from where it originated from, usually the patients are then considered not curable. So the goal is really to be able to catch the cancer early when you could remove it, and that's really the most definitive way to cure a patient.
But when they talk about pancreatic cancer, it's so hard to detect.
Oh yeah,
And
pancreatic.
it's late too when you
Yes.
find out.
Yeah, pancreatic cancer, unfortunately, is very difficult. We don't have any effective screenings. I mean, there is a blood test for pancreatic cancer, CA19-9, but it's not really used as a screening test. It's more used once you have a diagnosis. You could order the test to follow a patient. People get diagnosed with MRIs of the abdomen and with what they call EUS when they go into the mouth, like an endoscopy, but they use an ultrasound and they're able to see the mass and they biopsy with a needle. But all these things are once you already found some abnormality. The question is, well, what can we do to detect it early and catch it early? Right now, we don't really have good screenings for pancreatic cancer. That's really an unmet need, and I'm sure people are working on developing screening, but we don't have anything right now, unfortunately. And once you have it, if it's spread, it's a difficult cancer to cure and treat. It's really a tough cancer.
That's the sad part about it. Others have found solutions. Is there any? Well, there is breast cancer. Some females have it removed or there's treatment for it. Now, question: what's the difference between the pill chemo and the? Oh, where did you go,
Oh shoot, my bad.
Dr. Block? I'm sorry.
I didn't do anything. I'm here. So
What's the difference between the pill chemo and the one that's not pill? Is it a stronger version or not?
So in general, we have a lot of treatments for all kinds of cancers, and they involve pills, they involve injections, they involve infusions. So we have all these different modalities. The pills for breast cancer, I would divide them into different categories. We have initial pills that we give if someone has a what they call a hormone receptor positive, and those are hormone pills. I mean, they usually cause hormonal side effects like hot flashes, maybe some, depending on what the pill is. Either some pills cause joint pain, bone pain. Some pills may potentially increase the risk of blood clots. We also have other pills that are actual chemo pills, like, for example, what they call Xeloda, Xeloda, Xeloda. And that's a pill that's once we're ready to actually give a breast cancer patient actual chemo, we could give her that pill called Xeloda. And we use that same pill for colon cancer as well, when we're treating colon cancer. Xeloda is actually similar to other drugs we give in the veins called 5-FU. It's very similar, except it's a pill version of it. And I would say it's not necessarily less toxic. In fact, sometimes it could be more toxic than its own equivalent in the veins. So it really, you need an oncologist to kind of decide, which treatment, which pill versus IV is better for you. But what I've given Xeloda, for example, in rectal cancer, or for example, when we combine it with radiation, is when we want to. A patient tells me, "Hey, doc, I want to be able to work, and I don't want to pump, and that's constantly giving me chemo while I'm getting radiation, and I need to earn a living. I need to work." So I've just recently given a patient the pill, and I combined it with radiation to try to shrink his rectal cancer because it was locally advanced, and I want to be able to shrink it enough so then he could either get surgery, or sometimes I've had patients where things shrink so much between the radiation and the chemo and then more chemo that I give, that they don't even end up needing surgery. They're just watched. And that's the amazing thing of oncology. It's evolved so much that there are some patients where even just with chemo alone and radiation, they end up not even needing surgery. Now, what I do in those cases, and this is something that's evolving, it's something relatively new, because in the past we would always give everyone chemo, radiation for rectal cancer. We have to operate on them. I incorporate very advanced testing to further give me confidence that a patient could be left alone and not necessarily need surgery. So what I do for a lot of patients in this situation, and we could talk about other situations as well, is I check their blood for circulating tumor DNA. So I'm checking on a molecular level evidence of cancer, and I'm checking on a molecular level the response of the patient to chemo. And that's something relatively new in oncology. So I check their CEA level, which is a typical traditional marker we use for colorectal cancers. We do PET scans, CAT scans as well, where we look at the radiology to see the cancer shrinking with treatment. But in addition, I'll use a third modality, which is basically a blood test looking at a molecular level, and I'm quantifying, I'm actually saying the number. It gives me a number, and I look to see that the number is shrinking while I'm treating the patient. And frequently, if the treatment is successful and we don't see it anywhere else on imaging, I've got that number down to 0. And when that happened, a few patients that I've had, we presented them at our local tumor board conference, and there was a surgeon, a radiation doctor, an oncologist, and we actually ended up leaving the patient alone and said, "Hey, you don't need surgery. Just you got your treatment up front. You had a big mass in the rectum, no evidence of cancer on a radiologic level, molecular level. Let's just observe you." I had that patient now already 5-6 years, and they're doing good. And I just been monitoring them with follow-up CAT scans and follow-up molecular testing. So that's really exciting in the field.
Yeah, that's great news. Do they have to continue on radiology or anything at all?
Yeah, we usually will monitor patients for up to 5 years. That seems to be like a magic number in a lot of cancers, where once a patient had their definitive procedures like surgery, chemo, radiation, and then we monitor them. And after 5 years, usually, if there's no evidence of cancer, they're considered cured. But I would say there are a few cancers where you got to be a little careful. So it's cured typically for everyone, but something like breast cancer, unfortunately, uh, it's been known to sometimes have recurrences for up to 20 years later. And my theory with that is because usually it's typically hormone positive breast cancer, and because it's so slow growing, that they might have had some kind of little micrometastasis somewhere, and it just took forever to just eventually grow and grow, and eventually, after many years, it shows itself. Now, how do you prevent that? How do you what can we do about that? My answer is probably on a molecular level. I mean, when I check my patients for that circulating DNA, I'm
Right.
looking at a molecular level, and if they're positive, and that number that the report gives me is increasing, then I know that they have the cancer somewhere in their body, and I can't just walk away. I need to keep following them carefully, and maybe that's a patient I would do a CAT scan at least every year or every 6 months to a year, rather than say, okay, 5 years, you're done, you're cured, that's it. And that way I can catch a potential recurrence when it's early and hasn't spread very far, and be able
Which is great.
out. Yeah, so this is really the exciting part of oncology, the molecular tests that we look to see, to follow cancers, to look for recurrences. We're also doing these blood-based tests to see what the genetic profile of the cancer is. For example, in the past, every cancer, every lung, every cancer will be treated the same way if depending on where the cells came from. But now, when we do genetic testing on the cancer, this is not genetic testing looking for inheritance. This is
That's what I was just about to ask you. Hey, you know what?
genetic
If you
testing
did,
on the cancer.
okay.
This is to see what genetic changes the actual cancer cells have. And then what we do now, we could guide our treatment that's specific to that cancer. For example, lung cancers that have what they call EGFR, we have target for EGFR. Breast cancers that have Herceptin targets will target the Herceptin with anti-Herceptin drugs. So that's how the field has evolved, like in a very layman's kind of explanation, that we have tests for that. And that's also great, because these treatments are typically better tolerated than just general chemotherapy. They're better tolerated, and they're actually more effective.
And that's why research is so important, to continue to build and learn and find new ways and strategies to attack different types of diseases that come about.
Yeah, on a political level, that's why it's so important to continue funding. I mean, there's been in the news, and there's concerns about, maybe decreased funding for the NIH, and I hear about that. It makes me kind of nervous a little bit, because it's okay to like remove waste, fraud, and abuse, but don't cut funding for research projects, right? Because this is how developments happen. It's major institutions like the NIH, where they have all these clinical trials that allow us to be able to give these treatments. I mean, some things are made not be necessarily profitable for pharmaceutical companies to study, and so the NIH, that's also where they would come in. They would do additional studies that could help all of us live longer.
Wow, you've worked in Sloan Kettering prior, correct?
I did some rotations there. What happened was, as a resident, way back when, I tried to kind of learn from as many different people as I could. So what I did I grew up in Brooklyn, and maybe we'll mention that at one point. But I grew up in Brooklyn, and eventually I went to residency at LIJ. And what happened at LIJ, there was this really, really famous doctor, Dr. Rai. And he developed the Rai criteria for leukemia, and everybody's a friend of his, and everybody knows him all over the world. So what kind of cool about that was, because he was in my residence and he liked me, I was able to go and train with his friends in all different places. Nice. So I went to other hospitals. I went to London, and I went to all these places because all I got to say is, hey, I'm a student of Dr. Rai. Let me in and let me work with you. And they said, oh yeah, Dr. Rai. Oh, he's my friend. Come and you're always welcome here. So that was really my kind of a connection where I was able to kind of learn and go different places. And Sloan Kettering, I chose to do a rotation because they had this big program in psycho-oncology, and where they really had these dedicated specialists focusing on the biopsychosocial model and looking at all these aspects that are not necessarily medical, but everything else around it. And that was very, very valuable experience. There was an emphasis on communication skills, on breaking bad news, on talking to patients,
I don't know. They need a refresher. They need a refresher.
Yeah, but that was very rewarding and very interesting. And that really that helps because you're dealing with different patients with different problems, especially like in my case here in private practice. I'm at the front lines, and so it's very important to kind of looking at the whole picture, what's going on with the patient. People have depressed, people have social needs. I talked to a lot of the staff, even the staff that working in the hospice. People are juggling multiple jobs to earn a living. It's just a lot of people are going through a lot of hardships, and it's really important to kind of be aware of all these interactions between that and their health.
I have to commend you because, first of all, when you started the show tonight, you were ordering some delicious food from the door. We thought it was for you. You're busy taking care of your staff, making sure that they're okay. So kudos to you because the field that you're in is not easy. And especially when you have to break it to someone that, hey, you were diagnosed with this or diagnosed with that, or tell their family, here's what we're gonna do. What are some psychology that goes into the approach of having that conversation with the family or their young ones? What are some things that you do in order to support them, their whole, because their life is about to change? What are some next steps?
Yeah, so the key is to involve first the family. You really don't want to have the patient come in by themselves. That would be really, really rough. So I really encourage them to bring as many family members as possible. I have a whole bunch of fold-up chairs, so I could pretty much fit as many people as possible in my room. So that's the first step, is to have the family with them. And then and speaking to the patient, sometimes I gotta be careful because culturally, some cultures, they don't tell the patient too much, at least up front. So I kind of approach it gingerly. And these are the things that kind of they trained in all these courses and these electives that I did. It's like at Sloan Kettering. So I would ask them first what they know. I asked them, what do you know about your condition? And how much do you want to know? And I kind of very carefully approach the subject of the diagnosis to make sure that this is the correct moment to talk to them about it, rather than maybe break it down into steps, maybe to have them come back again as they absorb a little at a time. So it's really an art. It's really it depends on the psyche of the patient, how old they are, how young they are, what their level of social support is, and culturally, which if it's a culture that they may not want them to know, and I could be a potential ethical issue too, because it's hard to treat someone without telling them what they have. So so a lot of times I may have to tell the family, if I'm going to treat this patient, I have to kind of tell them. I don't have to necessarily make them depressed, and I could potentially not. I don't want to take away their hope, and I could
that part, hope.
Yeah, hope. Yeah, because a lot of cancers, there's always hope if they qualify for immune therapy. Some patients live a long time, and they have they're long responders on immune therapy, for example. So as long as we have options, there's always hope. There's always hope for almost any cancer. So you don't want to completely just cut them off and cut off all their hope, and then they're practically at that point don't want to live and don't want to even fight.
Right.
So it's a very, very complicated question, and the answer is almost impossible to give in a general sense. It's really very individualized, and I think at some point it does help to be working a long time, because it's something that you become better at as you keep working in the field. When you're starting out, it's tough. It's very, very tough, but it gets better. It gets better with age because you kind of have a better feel for what to tell the patient.
Experience. Yes,
That's why I keep the gray hair purposely, so at least they know I got gray hair.
You're funny.
Experience is the best teacher, they say. Is that because you said the importance of family and friends being there? Roderick had a lot of friends and family surrounding him, and you also mentioned hope and fighting. Roderick was a fighter. He had hope, and I believe that's why he survived so long after the initial diagnosis. Dr. Blokh, I know we're probably about to wrap up rather shortly, but thank you so much for
Wait, where can we get?
I just wanted to ask one more question.
Oh, okay.
One more question.
Oh my, wait. Go ahead.
So what sort of what you do, like Dr. Bryant said, is very, very difficult. What would you say is your success rate, or how many out of 100 patients, how many actually hit that 5-year mark where they are quote unquote cured?
Right. So I would actually kind of nuance that question by saying it depends on the cancer. But I would say there are some cancers. I'll give you specifics. CLL, chronic lymphocytic leukemia. The word is leukemia, right? And leukemia puts fear in anyone told that they have it. These patients, it's all individualized. There's a lot of risk factors, the risk stratification that we do, and we check them on the molecular level and all that stuff. But in general, most of these patients, it feels like they live forever, because I have patients, first, some patients don't require treatment, but regarding patients that even do require treatment, I have a bunch of patients that I'm in my practice that I already been seeing for over 10 years, and they have quote unquote leukemia. And what did I give them for this leukemia? I gave them a pill. I gave them one specific medication. It's actually a few pills, right? It's not just one pill, but it's one medication. And then they've been on this medication for over 10 years. And they're doing great with no side effect, which is amazing. That's CLL. Now, CML, chronic myelogenous leukemia, is also leukemia. And I can tell you, when I was a resident, I remember to this day, we had a young kid with CML that was admitted to LIJ. And, at that time, the prognosis was up to 3 years and you're gone. And Gleevec was just about hitting the market. It was just discovered. It was just hitting the market. And, they were trying to get it to the patient on a compassionate use because it was so early. And now CML is a chronic disease. It's just like diabetes. You just take your pill, and I have a whole bunch of CML patients, and they all pretty much, if something gets them, it's not the CML. It's a heart attack, a stroke, another cancer, something else. But I've had a bunch of patients, again, in my practice for over 10 years, just taking one specific medication, an oral medicine, and they have leukemia. And so that, and multiple myeloma. One more example. I'm not going to go through the whole list, but multiple myeloma. I mean, I remember, again, as a resident, the treatment was they had to get a pump, and they were getting chemo in the hospital. And that chemo, they got sick from that chemo. And then I remember thalidomide just came on the market at one point in the beginning of my career, and it was like a major breakthrough. And now, a lot of my multiple myeloma patients, some of them got transplants, some of them even didn't, but they're on basically non-chemo medications, and almost all the patients have responded to treatment, and they're living for years and years. I have a few patients for over 10 years with multiple myeloma, and they're doing great. Not doesn't apply to everyone, but in general, I have patients of mine with multiple myeloma are living past 10 years, which is absolutely amazing, considering that the treatments are some shots, some pills, and there's no chemo, and it's well tolerated. And I'm giving the full quadruplet that we give for transplant patients. So well tolerated, I'm giving it now to a lady in her 80s and she should tolerate it fine. I've lowered the doses a little bit, and chances are she's going to do amazing on it. So that's really the optimistic slant of oncology, is that people are doing much better today than before, and that's
Because
what
of
we
the research, yeah.
got to keep the funding going.
You're right. So politicians out there, please, we beg, continue that funding. We need some more research. We need people like you, Dr. Blokh, feeding your staff members, feeding your patients, creating relationships, because you mentioned you stay with them throughout the process, beyond the process, checking up on them. So relationship, that personal touch makes a world of a difference. So we value and appreciate you for all you do. How can people reach out to you?
Sure. So actually, my office number is 718-676-4067.
1
And I have,
second, Andre's typing that again. If you could repeat.
sure. 718-676-4067. And I have a website which has my telephone number, address, little autobiography of me growing up in Brooklyn. It's www.Dr. Ilya Blokh. Sorry, let me make sure I got the website right. It's going to be www.Dr., which is Dr. Ilya, ILYA, Blokh, BLOKH.com. So www.D, capital D, capital R, ILYA, BLOKH.com.
He's on the block. Yes. You need a rap song. You do need a rap song. Doc on the block. Yes. Doc on the block. Yes.
All right, Dr. Bryant. We leave that up to you to create one then.
Oh, you know what? I have the perfect DJ for you, because his name is The Block too. So I'm gonna introduce you guys. Horace, if you're listening, we need you to create something for
stop by. Have them stop by my office. Yeah, no problem.
Be like Top Dog.
Wait.
I'm gonna stop by for some curry goat.
No problem. You guys are all welcome to come by.
But here's the thing. You know what? This gentleman is from Ukraine. He's international. We're around it. He knows food, Caribbean food, like you, Chris. He's 100% Caribbeanized, right?
I'm from the projects.
So he's
Bayview. I'm from Bayview houses in Brooklyn.
Hey, Bayview in the house. Bayview.
Bayview. Yeah, I'm from Bayview. I actually grew
up. Rockaway Parkway, near the Bell Parkway, my friend.
Yep, I grew up from kindergarten to, I think it was like 11th grade. All my formative years was in Bayview.
Oh, what high school did you go to?
Midwood. I got bused. I walked bust, but Midwood High School. But I went to 276, Bildersee Junior High School.
Bildersee, yes. Bildersee on Rockaway, near Rockaway Park, near Flatlands.
Yeah, Brooklyn College and SUNY Downstate.
Brooklyn College in the house. That's where I graduated from.
Oh, wait, what year? Maybe I knew you.
1987.
Oh, I just missed. I think I was there like 88. I think I was there. So I think we just missed each other. I think the Speaker of the House where's the Speaker of the House? I think he went to Midwood, right?
Oh, Hakeem Jeffries, yeah.
Yeah. So
Midwood.
My brother went to Midwood, yeah. Great play. Well, thank you again for joining us, and please do not be a stranger. I know Roderick had wanted you on the show, and let me tell you, his family member made sure I had to have you on. So thank you, Dr. Blokh.
Thank you, Blokh. Thank you, Dr. Blokh.
Thank you. Thank you. Hopefully again. Thank you very much. Thank you.
Thank you, Doc.
And come back again.
Thank you. I would love to. Thank you.
Okay. Good night. So, ladies and gentlemen, you had a lot of information about cancer, about iron transfusion, about what to do, lifestyle, about how to stay healthy. And guess what? It all started from the block.
You're probably gonna be the singer, the backup singer, or the lead singer. Welcome to the block.
I kept thinking of J-Lo. When you kept saying that, Dr. Bryant, I kept thinking of J-Lo.
Oh. Oh,
Jenny
on
on
the
the block.
block. Yeah,
Jenny
yeah,
from the
yeah,
Jenny,
block.
Jenny from the block.
yeah. Jenny on the block. Oh man. But yeah, a lot's going on. We have a few minutes before our show ends. A recap of what's happening for this week or whatever. So lots been going on.
Gas still too high. Although the president said he's going to eliminate the federal tax, which is about 18%. I did see gas come down a few cents here and there.
I didn't see that.
Yeah, I did. If you go on gas station on Flatlands, it's 509, and 84th Street 509. In Brownsville on Brownsville near Mother Gaston, gas is 509 for super. So yeah, a couple places has come down. It was
Back to
525.
super? You went back to super or you went back to regular?
No, I'm going back to super.
Hey guys, do you use the Gas Buddy app?
The
Huh?
what?
Use the Gas Buddy app? Are you
No, I
No.
need to. No, no. What's that?
download the Gas Buddy app because it tells you like within, I don't know, whatever you set the range, like all the different gas stations and where the prices are the best.
All right, Gas Buddy app. All right, I'll look for it.
Gas Buddy.
Yeah, yeah.
I need to.
Come on, Village, download the Gas Buddy app, especially now.
Definitely.
That's an understatement. That is an understatement. But yeah, great thing. Great
It
conversation.
go down a little bit.
Huh?
I know the gas did go down, just a tiny amount though.
They don't feel
Yeah, a
like
couple of cents.
Yeah.
I was at $65. I'm like, please. Kidding me? Oh. Anyway. So any good things this weekend you're doing?
Getting drunk.
Drunk.
Ignore John. Chris, what are you doing?
Or a bundle weed too. That's what John Trump might do.
Yeah.
There
Smoke a
is
little weed at that.
party. About swimming earlier on. There's a pool party for one of my daughters that we're going to. I don't think I get to participate in that, but I will bring her to a pool party.
No, and watch. That's right. That's right. You watch. You're the fan. You know, our future. Exactly. John. There you go. A clown.
John, I'd like to know, what are you drinking?
Eldorado 15.
Andre, anything interesting this weekend?
I mean, my third book finally is on Amazon. I still got the three others still to do, so probably just gonna be working on those the weekend.
Okay. I get to sleep. Yes. Sleep.
Doc, that is a fib, Doc. You know that.
What happened?
You don't sleep, Doc. Next thing you know, you'll be in the office. That's what you all do.
I am
24/7.
going to sleep.
Yeah,
I'm
okay,
going
Doc.
to enjoy.
Yeah, Doc. I'm playing the violin, Doc.
Thank you very much.
Yes, congratulations, Andre. Congrats. Hopefully people get to go out this weekend and enjoy the beautiful weather
Oh yeah, I'm definitely doing that
coming
too.
up. So and I'll get to rest this weekend. So I'm looking forward to that.
I mean, yeah, you definitely need the rest. Because sometimes when you telling me how much hours you get to sleep, I'm like, what? So
Yes, but
yeah.
this weekend I'm committed to that. I am
Good.
committed.
Oh, playing the violin. On that note, villagers, thank you for another Thursday evening
Yes.
with us.
God
On the
bless.
Your success is not spoken, folks. It is done. Remember, you gotta take action. Take care of yourself, take care of your loved ones. And we see you all next week.
And remember what Sherry Ann said last week. What else, Andre?
Like, share, subscribe. All right, we'll be going up there. So definitely appreciate it because of the village. We get to continue doing what we gotta do. So the support is very much appreciated. So we appreciate.
And also raise a glass.
Raise a glass. Gratitude and thank you.
Yes, we miss you, our wonderful fearless
Roderick.
leader.
All right.
Yes, we do miss him, our fearless leader. But it's all good. We continue the legacy.
Amen. Let's continue it. All right. Good night.
Good
All right.
night.
Night.
Out.